she was presenting Maple and all the plans, and still that time I was following her and very happy to bring Maple 2014 to Germany, and since that time I'm working with Maple, and I love it that I have this functional, really this very, very correct EMG, and I think it's an important tool for diagnosis and treatment. So that's what I have to tell you about me and Maple and my relationship to Maple, what is since over 8 years already. So next slide, please. We come to the main subject today, to the endometriosis, and now I can't see it anymore. And pelvic pain. Pelvic pain is such an important thing in Germany, because the 11.8 people have pelvic pain from all chronic pain patients, and that's a lot. And in the last 2 years, endometriosis became more awareness, more attendance, and so I realized that that these women have really a lot of common with the pelvic pain patients, and they have pain during sexual intercourse, during defecation, and after prolonging sitting as well, during physical exertion, and sometimes with tight clothing also. The problem with the endometriosis is that these patients, the pain and everything, it's like a wave. So, and it's belonging to the menstruation cycle, and where they are, and their diagnostic and everything. So some of them haven't had very shortly the laparoscopic diagnosis. So, and a very important thing is that Maple is really small, so these women are not able to cope with the internal examination and a normal probe, and with Maple it's so small. And the other thing is, if they don't like, or if they don't can't stand the vaginal investigation or the vaginal treatment, we still have the option to do it from the anal part, and that's a big help, especially if you like to treat with electrical stimulation and you are directly on the muscle. So Maple can be used for the precise muscle assessment, but also it's sometimes easier than the vaginal examination. The main point is that the patient, so if I have my finger and Maple is something around that, a bit smaller than my finger, I have really long fingers. So if they can tolerate it, if they can tolerate my finger, and if I can move it gentle in, then it's quite sure that they can tolerate also the Maple probe. The other probes are just bigger. And as usual, we would love to examine the vaginal muscles before, to see how is the tone, and is it a correct contraction and everything. So, sorry, is there a right contraction, and does she use other muscles and everything. So for that reason, it's very good to to have this contact with an EMG. I explain later with the cases all these little hurdles you have to get over until you are fine with the treatment and with a good muscle diagnosis for the patient, because mostly people are told they have a hypertonus because they have pain, but that's not true, as everybody knows. Now, next slide, please. Next slide, please. Anu? Anu, can you hear me? Next. Yeah, thank you. Now I would just like to know, just lift your hand, your virtual hand, if you are a pelvic floor physiotherapist. Just 1, 2, 3, great. Some more? Or? Okay. Thank you. Are there more? No. And who's physician or gynecologist? Okay. Who's patient? Ah, okay. Great. Wow, wonderful. And other reason why you are listening to the webinar? Great, thank you. So I have an overview, and now from all important groups, somebody is around. So next slide, please. So now they have things together and they have things, they're separated, because the reason of chronic pelvic pain can be different. It can be after a trauma, after a fracture, back pain, a neurological diagnosis, surgery, the posture after sports, muscle dysfunction, craniomandibular dysfunction, and all these things. So pelvic pain can, due to many different situations, at least the pelvic floor is sometimes not powerful, not reactive, or has no endurance, or is just painful with trigger points. So for that reason, it's important to find out when, especially an endometriosis patient has no diagnosis yet, maybe they're moving together. So these pelvic pain patients, I have written it here, 11.8% of chronic pain belonging to the pelvic floor or to the pelvis. So that's a lot. And most patients needs 2 till 8 years until diagnosis was made. And only 20% are seen by a specialist. So there's a question, who is the specialist? What sort of specialist? Is it a muscle specialist, or it's a pain specialist, and give them just amitriptyline or whatever? So the other part, the endometriosis patients, their pain or problems are depending to the menstrual cycle, and usually, since they're going through the adolescence, it's painful. Most of them have had a surgery, have hormones. It starts during adolescence, and the painful defecation. And that's very interesting, because this sign is a main sign for the diagnosis endometriosis, but also it's a main sign for referred pain from the levator ani muscle, especially from the iliococcygeus and cubococcygeus. So all these things are going together. So I have written also the commonality. Pain comes and goes. there's very often referred pain. There's mostly dyspareunia. Some clothes are not tolerable. The pain medication has a very important part. Then they have urge. Some of them have depression. Some of them have incontinence because a pelvic floor who's not working, yeah, it's ending up quite often in incontinence or urge. And sometimes they have another pelvic floor muscle dysfunction or a hypertonic pelvic floor or weakness. Both are possible, but in Germany, it's the main opinion, okay, pelvic pain, hypertonic muscle, so just relax, try to relax. But if you have a weak muscle, or if you have pelvic floor muscle who's not powerful enough and caused by this leak of power, some muscles are overloaded and started to have trigger points, then it's like a trap. They are not able to get out of this cycle, and for that reason, I think it's so important to have a really good diagnostic and a treatment plan. And for that reason, you need to know what you're looking for. And so it's important to make a very good anamnesis, to look for the history of pain and of the history of the endometriosis, if there are other things as well. So what I have seen. Is there a question? Okay, I carry on. So for that reason, it's also important to think about the history, especially with pelvic pain. What I have seen very often, there are patients who has had a history of intensive sports, not almost like a drug, but some of them are doing a lot of sports and stopped immediately without any reason, or that changed the situation changed, like they started to work or moved into a different city, or have had an injury, needed to stop the doing a lot of sports. So all these things we have to see in the history before we start the treatment, and more specific diagnostic. So the next part would be my first case, but no, oh no, can you put that? Yeah. Just an overview of the muscle groups on the layers. When we see in a minute the first case, I put this in that you know the bulbus spongiosus, the urogenital diaphragma, the puborectalis, and the pubococcygeus. The pubococcygeus and the iliococcygeus you should have in your mind, and also the puborectalis, and because there are quite, they have quite often an important part of the problems. I don't know if everybody knows it. The puborectalis is the most important muscle for the continence, because it's pulling from back from the coccyx behind the rectum. It's pulling forward direction to the symphysis, and then the urethra will be closed. So, and the pubococcygeus and the iliococcygeus, they are stabilizing the dorsal vaginal wall. So that's important for stabilizing the back part of the pelvic floor. So if you have an overload or problems there, then sometimes there are they are working harder than there should be, because other muscles are not on the team, and so they have to work harder. And next slide, please. Some muscle groups and layers from the anal, we have seen it again, and so for that reason, I really love the anal measurement, because I have really a good overview about the pubo and iliococcygiosis and about the puborectalis. And the pubo and iliococcygiosis are connected to the back pain caused by the near to the sacrum and the functional part of the iliosacral joint. So if the pubo and iliococcygiosis are very tense and have trigger points and are not powerful enough or too powerful, then I have seen with my patients a correspondence with the back pain. So next slide, please. So we are coming to case number 1. Her name is Anna. She's 39. She's married. She has had 2 vaginal deliveries. She has had non-birth trauma. She is part-time in an office job, and she has had 3 times surgery caused by endometriosis. So all are laparoscopic. And her medications are hormones, and she changed her diet. It's a very important part for the endometriosis patients, really to look for the special diet. Her symptoms are belonging a bit to the menstruation cycle, with back pain, weakness, vaginal trigger points, and urge with leakage. Her sports are swimming and Nordic walking, but when she has really a bad time, then she's not able to do it. Important is the medication with the hormones. That was very difficult because she has had, they needed to change it, and for that reason she has had very slight bleeding. So it's a cycle, and it's difficult for these patients to work all the time with the pelvic floor. So next slide, please. So we can see the 27th of May 21st, so 2 years ago. And I have seen, I decided to show this to you because she was, when she came first, she was a really, really pain patient. But if you look at her results, you will see, oh, interesting. She's not hypertone, and the vaginal investigation, so the tone was really weak. And you can see, if you look at the black and white one, you can see at the part of puborectalis and part of iliococcygiosis are normal, just normal tone. And also you can see at the quick contractions, the puborectalis on the one side is working better than the other side. And if you look only at the black and white one, then you can see, oh, that's interesting. It's working quite nice. The left side, the right side on the black and white, but not really good. But if you look on the other part, you can see, well, it's weaker than normal, weaker than the normal population. And the same with the endurance. So what can I do with these patients, with such a patient? So I would do an electrical stimulation. Oh, that's what I did. Also, we are stimulating, and because of the left side, I decided to give her a stimulation on her right side and the back. So, and during the time, every time when we could do it, so that's a very important thing with the endometriosis patients. You have really waves. You can't do almost the same. And she's quite lucky. She's private insured, so she can come really so many times she needs to come, so many times she needs a treatment, and it's for her the possibility to go to work, to live her life. She has 2 children, so everything it's quite okay, but she has to do a lot for herself. And after the stimulation, we could see it's much better. So so if you go to the next slide, please. Yeah, you will see after a while, that was June, it changed. All the colors are changing. Now you have more, yeah, you have even the red light, but you can see in the middle, the muscles are working much better. So just the training with the electrical stimulation was very successful, even in a few weeks. And her tone became also better. So if you think the first one, it was more dark blue as before, and the black and white one was also, and now we have 3.3, so we can also see it's improved in the tone. Her quick contraction, there she has sometimes you can see it, it's quite the highest EMG is very high, but that's caused by the trigger points she has. And if you have a trigger point, you have almost I show it later in a slide, you have very high contraction and not a good relaxation caused by the trigger points, because the point is not very flexible in his answer of contraction and relaxation. If you see the right one with the endurance, that's much better. It's still not perfect, but this is after 4 weeks treatment. So I think she improved a lot. And what she said was that, so I was reading in the record for preparing this webinar, what she said was her feeling it's much better because of the pain. She lost a bit her feeling for the pelvic floor and how to contract. And when she has these cramps during her menstruation or before, then it's a difficult situation to relax, to be aware, to contract properly. So it's helpful to see where to focus. Next slide, please. The case 2, it's a very interesting case. It's Stephanie, she's 22, she's virgin. There's no gynecological examination possible. She has had bad experiences as well. She's a student. She's doing yoga regularly around 10 years. She's swimming, and she has very hard abdominal pain referred to the pelvic floor and to the bladder. So also she has a painful defecation. She has no endometriosis, and she has no interstitial cystitis. Her pelvic floor is only 2 of 5 with a high discoordination, and she has really painful trigger points at the pubo and iliococcygiois. So it was able to make the internal investigation. And now next slide, please. And I gave her, it's something what I'm doing. I give these patients the maple probe at home, so she can try lying on side to insert it or try to get through this resistance. Some patients are using dilatators to get over this. So you can see on your left, on the left, you can see the 1 minute testing. You can see at the iliococcygiois and that there's a higher tone. She is 2.4, but when you investigate her, it's it's first a bit tense, but then it's quite soft. So she's also hypotone, and you can see there's not a lot of activity. And after the electrical stimulation, you can see it's more tone, and she can also better contract. So if you go to the next slide, you can see the contraction before and after. So, and on the top left, you can see there is not a lot. It's a bit up, and then it's going down, and there's not a good relaxation as well, and also with the activity. But after she got this specific electrical stimulation, she was able to do a contraction and relax. The relaxation are still not perfect, but it was the first treatment. And also you can see on the endurance and the graph that she's able to contract, hold a bit, and relax. Not perfect, but it's possible compared to the other side. So that was one session, and I gave her only the electrical stimulation outside, so the 4 rings from external to internal, and the internal 2 rings I stopped. So she was supported and got another feeling, and she knew where is the pelvic floor and could feel it. So I think I did 15 or 20 minutes. But I feel almost impressed how fast the patient can change the awareness when they are shown, okay, there is more. And also before I stimulated, I did trigger point treatment. So this I have to add to my information. So yeah, I think for one treatment it's a very good result, and she's coming once a week as well. And I do it like 4 times once a week, and then I see where we are standing. And so that was very very pleased. So next slide, please. That's case 3. That's a mistake. It's Melanie. She's 27, no birth, no lipara. She's in a relationship. She has painful menstruation since adolescence. She has painful intercourse. Since she has had first time intercourse, that's very interesting because many women are telling, yeah, I thought it's normal, because it's a very shameful situation. And 2022, she got the diagnosis endometriosis and started a special nutrition program, started with hormones, and in 2 weeks' time, she has her laparoscopic surgery in a hospital who's specialized on endometriosis. So, but a very important thing for these patients who are listening, I spoke with my patients especially about the webinar, and I'm very pleased that they're so often are telling me how ashamed it is for them to talk about painful intercourse when they're so young, because they're almost thinking it's something wrong, and it depends to the partner and the relationship if they can handle it. But still they're thinking, okay, may it's normal, may it's only, yeah. However, so it's not nothing to be ashamed. So, but it's for us as a therapist or as a physician also, we have to have this in our mind, that so she has, I think she has a history of diagnosis of 4 or 5 years. So if you're going 4 or 5 years or longer from one person to the other, then you're really desperate. And you also listening to some funny theories about your pain and everything. So, but the special nutrition program, that all patients are telling me this, it gives a really step forward. So now we look at her. Please, next slide. And you can see that's a vagina. So we did a vaginal and an anal one. So and you can see there is it's so hypotone. And she has also what she described, she has not a good feeling. So I teach her the right contraction, and then we can see here overload of puberectalis, iliococcygiosis, and the endurance, it's much better. If you see the onset and offset from endurance and from the quick contractions, you can see it's higher, or the difference is higher at the quick ones. She has, when you now look to the healthy group, you can see she is hypotone and the resting period, but then she is, and the quick ones, she is more with the puberectalis and iliococcygiosis, quite intense, but in endurance she's working very hard. So, and then you see the other muscles are not included. So that's very interesting. We go one step next. So the next slide, please. Then we have the anal one as well. So again, it's a quite good resting situation. And the anal one shows you a differentiation. So compared to the healthy group, and I love to show my patient the healthy group as well, because it's more that's something all of them would love to know, because they're thinking almost, oh, I'm not good enough. But it's more clear, and sometimes you see these colorful pics, and it's easier for somebody who's not used to all these shadows, what we are. So it's really nice to see the colored one and to have a target to say, look, on some spots it's too much, and now we're stimulating it. So it rectally on your left hand side, the lower peak. There is it's more contraction, and it's more. I feel it looks more sorted, but still we have a long way to go to have a proper contraction, because you can see if you have to go. That I didn't want. I have to move this. You can see the differentiation from the normal contraction. It's in the beginning something like with the quick ones with 14.9, with the endurance 19.5, and later on it's 15, so, and 22. So it's higher because she can contract better. It's still some discoordination inside. So if you look of the highest EMG, you can see it's a bit too much. So, but that was one treatment. So next slide, please. I think there's another one. No, I haven't put it in, because when I was looking on the graph, then you could see there is a discoordination. So when I have can you go back, please, because that's important if you have a treating plan. When I see the higher, or the high EMG rate is more than 10 between the median EMG, then I almost look at the graph, how they are handling it, and I sometimes I take some screenshots to see it, and I'm talking with the patient where's the problem. And so the next step with this patient would be, after the electrical stimulation, I would give her the opportunity to concentrate only on one part of the muscle, that she is more able to look bulbus sponghiosus and the external sphincter. So bulbus sponghiosus vaginally, and the external sphincter, and the puborectalis anal one. So all these things you have to have in your mind when you see these pictures. Sometimes when there's a high, so I almost look for something like 10 with 5, I have no problems. But if it's 10 or more than 10, then I almost look at the graph and talk to the patient where's the problem. And see on, sometimes it's helpful to do some electrical stimulation to have more awareness of these muscles, or to have more power, to give there some power in to connect the muscle again to the brain. Okay, so that's important to this patient. So next slide, please. This is a patient, I didn't write anything, because it's important to see what's happened there. So we see on our gray shadow resting tone, there's a bit, it's anal again. There's on the pubococcygiosis, ischiococcygiosis on the right side, and on the back side it's a bit more. And you can see on the fast contraction, the other part is not the right, the left side is not working. But in the endurance, there you have a leak on the back. And if you look at the coloring one, you have the same as well. And the puborectalis and the sphincter ani externus and the endurance are not very good, and the quick ones it is. So now the next one, please, next slide. Yeah. And now you can see, wow, that's the graphs. So why did I look at the graph? Because it's a pain patient. It's a pain patient, and I wanted to see, and you can see it's going up and down, up and up, and then a bit down, and that's something what all trigger point muscles are showing, and it's a part of the diagnostic of trigger, something Simon Travell found out already in the 70s. And the great thing with Maple is we can find out which muscle is it. We can stimulate just this muscle, and then we can teach the patient. And that's what I love. And if we go to the next one, please. And I put the graph down after the treatment with the electrical stimulation. You can see it's a difference. It's the endurance one. And suddenly she was able to contract properly. And again, I did the trigger point treatment. I teach her one curve, only the external and the puborectalis muscle, and also I gave her the electrical stimulation for a better tone for the three external rings, so the puborectalis and the sphincter ani externus. And after that, we did it again, and we have this nice contractions in the graph. And that's something, it's motivating a patient as well. And so that was that's my patients. I would like to introduce you, because I think there are, that's very important to see how different and how similar they are. And now the conclusion. Next slide, please. So the conclusion from this session is you have to think about what do you need to ask the patient. So that's important. How's the history? And with these patients, with pain patients, endometriosis patients, it's the history very important. Are they doing sports? Are they have, when did it started? When is the pain? And all these things, what sort of treatment they have had, what they are able to do, how's the daily work, and everything. So you need really a good overview about the lifestyle of the patients and nutritions and everything, and what have you done and what's helping. That's very important. What do you need about the tone? You have to know, is it hypertone or hypotone? And when you feel the tone, it's very soft and there are some tender spots. You have to think about trigger points, and you have to watch the fast contraction graph. Yeah, you have to look at it. You have to see if it's not symmetrical. You have to watch it. and you have to see if there's tender spot, and then you have to treat it as well if you are able. And on the other hand, you can stimulate the others and see what happens, because the tender spot is coming because of an overload after a stretch, an overstretch, like a childbirth, or caused by the other muscles are not working for some reasons, an overload because of cramps, because it's so painful, and so that's something you have to be aware about. Why is the tone not just not symmetrical? And you have to look for the multidisciplinary treatment, and that's good to send all these pics to. I almost give my patient an overview, the three, what I have shown to you, and I write something on, or I send it to the doctor when we have this agreement. So what we have here in our hospital, I'm do the documentation together with our doctors. So they get it immediately. So that's a very, very pleased situation, because especially with pain and home devices and everything, it's important to talk, that we all talking together and not only one person. So most pain patients or many endometriosis patients have also they have an endocrinological treatment, they have a gynecologist, some of them have a pain therapist, and a psychology support. And for that reason, it's important to have this optimized documentation what Maple gives us. So I'm very happy since 2014 to have the possibility to work with that. So if you have any questions, I'm open for it, and I hope you enjoyed the webinar.